Cardiovascular Pharmacology, beta blockers, class 2 antiarrhythmics. All right, so for our class 2 antiarrhythmics, these are just our beta blockers, okay? Just how class 1 was sodium channel blockers, these ones are going to be beta blockers, and they're going to help us with rate control. Now, before I get into the antiarrhythmic effects of beta blockers, we didn't really have the chance to go over beta blockers as a whole and what those drugs do and their actions. And there's so much that's indicated when it comes to beta blockers. So I want you to understand kind of just the general principles of beta blockers and why we use them and kind of their actions and just some notes about them before we actually get into the antiarrhythmic effects for class 2 drugs. Once again, before I start this, make sure that you go on Sketchy and watch the beta blockers video and then also watch the class 2 antiarrhythmics video. Both of these are going to be very helpful for your understanding of what you need to know when it comes to all this. Okay, so first and foremost for the beta blockers, if it ends in lol, then you're dealing with a beta blocker. Okay, very easy. Atenolol is a big one. And then like pretty much all of them. I'm not going to go through them all, but it's very important. Now, application usage. So the first one that we're going to be using it for is angina. Okay, so anytime that a patient comes in with that chest pain angina, secondary to some type of ischemic heart disease, and they have angina, you're going to give them beta blockers. And the reason behind that is because you want to relax the heart. You want to make sure that the heart's not working too hard. Okay, so that's the whole entire point of giving a beta blocker for angina. So what it does is it's going to drop the heart rate and decrease contractility so that overall we're going to decrease our oxygen consumption. That's the point of beta blockers. We don't want the heart working too hard because if the heart works too hard, then it's going to have more oxygen. More oxygen means more blood flow needs to come to that area. Well, guess what? You have ischemic tissue. We don't want it to work too hard. So overall, it's going to drop O2 consumption. Very important. And it does that by decreasing heart rate and contractility. Next, we could use beta blockers for heart failure. Once again, this is going to be a drug that decreases mortality. Very important. Remember that those decreased mortality drugs are very, very high yield. So remember that beta blockers is one of those drugs that decreases mortality. And the way it does it is it causes a blockage of neurohormonal stress, okay? So overall, we have prevention of cardiac remodeling. And that's something that they really like to say. So you block cardiac remodeling by giving patients beta blockers, and it overall decreases your mortality. Okay, next is hypertension. It treats hypertension. The reason it does this, decreases cardiac output, and it decreases renin secretion, which is weird. But the reason behind that is because there's beta-1 receptors at our JG cells which release renin, okay? And we're going to talk about it later on in the renal section. But something that's important to know is that we don't only have beta-1 receptors at our heart, they're also located in the kidneys at the JG cells which release renin. So when we give beta blockers to any patient, you're going to see an overall decrease in renin secretion, okay? And so once again, that's going to be helpful for hypertension. Next, beta blockers can be used for hyperthyroidism. Very important to know. It's just for symptom control, but we'll talk about that later on as well. And propranolol is usually the drug of choice there. We could use it for hypertrophic cardiomyopathy, for decreasing heart rate, once again, which leads to an increase in filling time. Okay, so if we decrease the heart rate, that allows for more time for the ventricles to fill, right? That's all that it is. And it relieves the obstruction. Because what did we say? Is that for hypertrophic cardiomyopathy, specifically hypertrophic obstructive cardiomyopathy, if we have less blood, then the obstruction is closer to, so then that wall is able to move anteriorly and obstruct easily, right? So more blood means less of an obstruction. So that's why beta blockers are really helpful for decreasing that heart rate, leading to an increase in filling time. So more blood goes through. And that's why hypertrophic obstructive cardiomyopathy is one of the only murmurs that actually decreases with more blood flowing through it, just like mitral valve prolapse. Those are the only two, right, overall, that have a decrease in their murmur with an increased amount of blood flow, okay? Next, beta blockers can be used for myocardial infarction. Once again, it decreases O2 demand, right? Decreases O2 demand, decreases mortality. That's all we need to know for myocardial infarction. Very important, okay? So the type of beta blockers that you have to know, they're going to quiz you on, is beta blocker that are cardioselective, so specific to beta-1. Okay, so beta-1 blockers, because they're specifically blocking that beta-1, which is located in the heart muscle. Okay, so they call those cardioselective drugs. And the way that you remember that is via the mnemonic A-beam. Okay, so A-beam. So the cardioselective drugs that you have to know that are specific to beta-1 blockers are going to be your atenolol, okay, that's the A. And then you have bisoprolol, esmolol, metoprolol. Okay, those are like the main ones. Okay, there are other ones, but once again, A-beam is like your favorite. It's gonna be your best friend. Okay, they're beta-1 specific. Now there could be other drugs, other beta blockers that are not beta-1 specific, but they do have beta-1 and beta-2 effects equally. Okay, and that's nadolol, propranolol, and timolol. Those are both beta-1 and beta-2. So non-selective antagonists. And then lastly, you have non-selective alpha and beta antagonists. So these beta blockers can also be used to block our alpha receptors. And these are questions that they love to ask. The two of them are carvedilol and labetalol. You have to know those, okay? To me, the most important is A-beam, which is beta-1 selective, and the non-selective alpha and beta antagonist, which is carvedilol and labetalol. Okay, so know those, understand that, and it should be really helpful for understanding overall what beta blockers do. Lastly, beta blockers can be used for glaucoma, and we're going to talk about that in the neuro section. For eye, specifically timolol is going to be used, okay? And all it does is it decreases production of aqueous humor. All right, now, lastly, beta blockers can be used for antiarrhythmics. That's why they are our class 2 antiarrhythmic drugs. So once again, if you see LOL at the end of the name, then you know that you're dealing with a beta blocker, and it could be used for rate control. Okay, so these are rate control. And once again, pull up that graph. See what is occurring when we're giving patients beta blockers. The mechanism behind this is that we're going to have a decrease in the SA and AV node activity. And how does it do that? We're going to decrease CAMP, which leads to an overall decrease in calcium currents. Okay, so this leads to a decrease in the slope of phase 4 of our SA and AV node action potentials. Okay, remember in the SA and AV node action potentials graph looks different than all the other cardio myocytes graph. Okay, so this one is going to look a little different. So what you're going to do here with beta blockers is that you decrease the slope of phase 4 through decrease of CAMP and decrease in calcium. But you run the risk of increasing the PR interval due to the fact that you have AV nodal sensitivity. Okay, so you have an increased risk of making the PR interval longer. Okay, esmolol out of all these is the shortest acting one, and it can be given IV. Okay, and that's a question that they like to ask. For clinical usage, once again, what did I tell you? It's rate control for AFib. Okay, so we said we treat AFib via rhythm control, rate control, and anticoagulants. So the rhythm control we already discussed, class 1C, and there's also going to be another one later on. Rate control is going to be class 2, okay, which is the beta blockers, and there's going to be another one later on as well. Okay, so this just helps with the rate, and that makes sense as to why it affects the SA and the AV node, because we know the SA node, right, what is it? It's the pacemaker of the heart. So if we can control the pacemaker of the heart, the action potential of the SA node, right, the cells at the SA node, then we could overall control the rate, right? So I hope that connection's there. So the ones that control the rate control, they affect the SA and the AV nodal action potential graphs. And the ones that affect the rhythm control, they affect the cardiomyocyte graphs. Okay, so keep that in mind while you're working through it. Okay, so that's very, very helpful. Lastly, some adverse effects that you could see is impotence, okay, in males, and you could have exacerbation of COPD and asthma. That's something that they might ask about. Lastly, it can mask the signs of hypoglycemia. So if you have a beta blocker and the patient is hypoglycemic, they might not notice. They might not present with hypoglycemia. Okay, and the question they'll ask you is that this patient's glucose levels are like in the garbage. They're like 20, okay? And they're still walking around, they're fine, they're not doing anything, they're awake, they're alert, they're oriented. Okay, well, check their medication list to see if they're on beta blockers, okay? Lastly, if a patient overdoses on beta blockers, the question they like to ask is, what do you have to give them? You have to give them saline, atropine, but glucagon. Glucagon is the most important one, okay? And the way that it does this, the glucagon works, is that the way it treats the overdose is by increasing cardiac myocyte CAMP, right? So all you have to do is increase CAMP in the cardiac myocytes, right? Because beta blockers overall decrease CAMP. So if I have an overdose of that, I'm going to have a complete loss of CAMP. So I have to replenish that CAMP. Okay, and the way that I do that is giving them glucagon. All right, so I hope that kind of helped you a little bit with beta blockers and what they're used for. Remember that they're a decreased mortality type drug that's very high yield. And then the different specifics about it all, you have to separate the antiarrhythmic effects via the rest of the effects, and you should be good.